So it's all live now?
Yep.
Perfect. That's fine. I can just display on here somewhere.
Yeah.
Let's try.
Perfect. Can you check the live stream? You want to repeat first year? Do you want to repeat first year?
Can you guys see it back? Yep. Perfect. Alright, so I'm gonna get started. Sorry I'm a bit late. I was adding questions last minute, but yeah. So last few revision lectures for you guys. It's been a great year. Thought I'd wear the same shirt I saw for, you guys for the first time in. Made some shit joke about this set on me. Fuck, I can't even say English right now. Saying Calvin, whatever. So I'm gonna go through cardio, back and thoracic anatomy for you guys. It's pretty high yield. It's the highest for your exams. And I'm going to do a few clinical skills cases whenever they're relevant. Yeah. So everything that we discussed today, I will have covered in my year, but you may have not covered. So just be aware of that. If you're worried about something being on this and not in your notes, that's fine. Ignore it. If this contradicts anything that you've got in your notes, then ignore this as well. Go with whatever your lecturers have said. And I'll be breezing through this because I got way too little time. All right, so first question. Good answer? All right, so the answer is C. I'll go into that later. All right, so just essentially this first quarter is all about that confusing revision lecture, or not revision lecture, that embryology lecture by Lazarus about the whole folding and all that shit. So this is just the basic points that you need to know. Starts in weeks 3 to 8. It's one of the first organs to fully develop, and it starts in the neck, and that's why you have a lot of the cranial innervation that you've got. When you start off, you have 2 bilateral endocardial tubes, and they fuse together to make one heart tube. And yeah, atria start inferiorly, ventral start superiorly, sorry. And that's just a nice image. Now, these images, I found a bit confusing at start as well, but just to note where the orientation is. So you've got a lateral view at the top and a frontal view at the bottom. So on the lateral view, you've got anterior on the left and posterior on the right. So you can see how the ventricles they grow significantly, and they go up and around. So that makes it the heart roll over, I guess, in a way. And sorry, wait, what was I saying? The ventricles grow significantly, and that forces the atria superiorly, and that makes the atria end up superiorly when they started off inferiorly. And so the end positions of the atria are posterior and superior, and ventricles are anterior and inferior. And this is a really good table that she indicated, and she put in her slides. The main way you can interpret this is just to look at the diagram and think, okay, so we'll start with the primitive ventricle and atria, and essentially everything's gonna be relative to that. So if you have these primitive atria, they're going to be the main areas that you'll have the ventricles and atria. And then everything around that, the bulbous cordis, the sinus venosus, and everything like that, they're more vascular structures. So they're going to be smoother. So that's why I get the smooth part of the right ventricle, blah, blah, blah. And notable exceptions are the truncus arteriosus and the left sinus venosus. So you've got in the truncus arteriosus, the aorta, pulmonary trunk, and semilunar valves, which are the outflow tracts. And the inflow tracts for the left sinus venosus are the coronary sinus and the oblique vein, left atrium. And the endocardial cushion is the thing that that signals towards it for everything to grow towards. This is a quick summary of what of the processes of atrial septation. So first of all, you have the septum primum, the flappy one. So that grows superiorly from the superior border inferiorly towards the endocardial cushion. And that gap between the superior margin and the endocardial cushion is the first foramen primum. And note that ostium and foramen are the same thing. They just like to confuse you. So once you have that foramen primum, what happens is once it fully develops, that first, I guess, ostium or layer, there you have apoptosis at the superior end, which ends up being the foramen secundum. Once that happens, you have growth from the inferior wall, from the posterior wall of the septum secundum, and that forms the foramen ovale. And then once these grow enough, you have a way for blood to travel from the right atrium to the left atrium and then throughout the rest of the body. Any questions? No. So, question. And Henry loves C? Correct. You've got 3 shunts in the body. This is the first shunt. I'll go into the other 2 later. So the foramen ovale is one I just mentioned, and that becomes the fossa ovalis in the adult. So what happens is, throughout the whole of the fetal development, you're right, the right-hand side of the heart has more pressure. So that pushes blood from the right atrium to the left atrium because you need to bypass the lungs because they're still full of fluid at the moment, because they're in the placenta and everything, and that doesn't work. So once you have the first breath after childbirth, you can finally aspirate the lungs, and that decreases the pressure and resistance in the pulmonary circulation. And that decreases the pressure on the right-hand side, and therefore the left-hand side has greater pressure. So that means that now you've got an area of greater pressure on the left-hand side, and because you've got the septum primum, which is the flappy one, you have greater pressure on the left-hand side. It's pushing the flappy part against the rigid septum secundum. Sorry, not second. The septum. Sorry, the septum secundum, and that creates a physiological closure. And this ends up closing anatomically after about 4 weeks to 3 months and becomes the fossa ovalis. And these are 2 clinical points. So there's a difference between atrial septal defect and propatent foramen ovale. So for the first one, you have a complete overlap of the foramen secundum and foramen ovale. And you see here, there's a slight discongruence between where they are. And that allows for the shunting ability during the fetal circulation. Whereas in the adult, this is a problem because that allows blood to travel from the left atrium to the right atrium and out through the body. And that makes you lose oxygenated blood from the left-hand side heart. And that's a bigger problem, and it's rarer than propatent foramen ovale, which isn't a problem. It's just the problem is that you don't anatomically close the foramen ovale, and it doesn't become the fossa ovalis. So it's still open, but under normal circumstances, you have a greater left-hand side pressure in the heart because the left-hand side pumps the systemic circulation. So because you have that, that's no problem, because that flappy septum primum is being pushed against septum secundum, and it's not causing a problem. The only problem occurs when you increase pressure on the right-hand side, for example, when you have pulmonary stenosis and it's hard to push blood out, and that increases right-hand side pressure, and that allows blood to flow back into the left-hand side, creating, pushing deoxygenated blood into the systemic circulation, essentially. You have ventricular septation as well. It's very simple. It occurs at the same time as atrial septation. And if you have a ventricular septal defect, that's a big problem because you have lots of mixing of blood. Yeah, next question. Have you guys done tetralogy of Fallot? Yeah? No? No? Is it a yes or no? You have? Oh yeah, if you have done it, then you hopefully should know this. All right, so the answer is E. And I've listed them in order in terms of how they, like the way I remember it is it's kind of a mnemonic in the sense that you can learn it as a random mnemonic as proof, or I like to learn it sequentially. So you actually like to think through the condition itself. So you start off with ventricular septal defect, and you have, as a result of that, you have an aorta that can override both ventricles. And because you have an overriding aorta, that increases pressure in the aorta, and that can, I think, decrease the area in the pulmonary trunk, which creates pulmonary stenosis. And pulmonary stenosis makes it harder for the right ventricle to pump, and that creates right ventricular hypertrophy. So if you think of it as sequelae of ventricular septal defect, it's much easier to remember. I'm not sure if it's actually like this, but it's a great way of remembering it, I feel. Great. Quick one. B? Correct. Another one. And this should be pretty easy. I already covered it, so. Just shout out. Perfect. All right, so twisting septation occurs. So you start off with them in a weird orientation, but then eventually in the adult heart, you end up with the aorta posteriorly and the pulmonary trunk anteriorly, and that correlates with the cusps. So you have in the aorta, which is posterior, you have the posterior cusp and etc. And these are some problems when the truncus arteriosus doesn't septate properly. So you either have persistent truncus arteriosus, which is when no septation occurs at all, and you have mixing of blood. And another problem is transposition. So that's the failure of the spiraling septation. That means that the aorta comes off from the right ventricle and the pulmonary trunk off the left ventricle, which is obviously a huge problem, and they both require surgical intervention. That's a, wait. That should be ductus arteriosus, so I'll correct that. Very good. And this is just a quick summary table of fetal heart versus adult heart. Note the right-hand side greater pressure, left-hand side greater pressure. Yeah, that's pretty much it. And there's no shunting occurring in the adult heart at all, whereas in the fetal heart, you've got the foramen ovale, ductus arteriosus, and also another shunt in the liver, which I'll go to soon. So these shunts should all be closed in the adult heart, as I just said, and you want to move blood away from the lungs and the liver. Those are the two main organs that you want to avoid during fetal circulation, and those are the three shunts. You've got the foramen ovale, top two we've already covered, and ductus venosus is no one will cover now. That's the same size as before. Okay, so an important point with the ligamentum arteriosum is it's the closed version of ductus arteriosus. So this shouldn't be open in the adult. And by adult, I mean just like post-birth after like half a year or so. And a very important relationship between this is the left recurrent laryngeal nerve, which runs underneath the aortic arch. And if you have some kind of coronary surgery, if you manage to nick that nerve, that laryngeal nerve, as it suggests, goes underneath the aorta and then up and supplies the larynx, which is like the voice box, right? So if you damage that, you're going to have a raspy voice post-surgery. That's like a buzzword kind of thing, raspy voice. And it's there. And the ligamentum anterosum should be there, but it's occluded, so it's not shown. And this is the last point. This probably isn't too high yield. It's just showing that the ductus venosus moves blood away from the portal vein, the hepatic portal vein, which is the main kind of blood supply for the liver. And what happens is it moves it from the umbilical vein, which is where it gets most of the oxygenated blood from the maternal circulation, into the inferior vena cava and into the heart. All right, anatomy. Perfect. I'm not going to patronize you with this. It's base of the heart, apex of the heart. You just know that. Yep. You want to see? Yeah? Perfect. So an important point to know about the papillary muscles is that they only anchor the cusps. They don't actually contract. If they, because it's a muscle, you think it's going to contract, right? But the main mechanism of opening the AV valves is by increasing the pressure, and that's going to just push blood into the ventricles. They just prevent prolapse and prevent it from going inwards. Otherwise, yeah, and they're only for the AV valves, not for the semilunar. Yep, and the mitral is only one with two cusps. Yep, already covered most of that. And note for the aortic valve, for the right and left cusps, you've got the opening for the right and left coronary arteries, respectively. Just a few points about regurgitation and insufficiency. So when you have normal valves, you have, it allows for laminar or smooth flow in one direction. Whereas if you have valvular stenosis means like abnormal narrowing, the opening is impaired and you can't get blood like fluidly through. So what happens is you get the turbulent flow and the murmurs that you've auscultated in your clinical skills. And when you have insufficiency or regurgitation, as it suggests, the blood can rush backwards as well because it doesn't close properly. Yep. See? That's fucking gunning it. Well done. Or maybe there's a really easy questions on that. E? Very good. Remember that the visceral layer of serous epithelium is the same as epicardium. They're just synonymous terms. So the pericardium, pretty important point. So it's innervated by the phrenic nerve, and that creates your right shoulder tip pain. Left shoulder tip pain. Should be left. And the pericardium is phrenic pain innervation, so that makes sense. You have the fibrous pericardium on the outside, which anchors the heart towards the great vessels and things like that. And you have the serous pericardium, which is a continuous structure, just like the pleura, which you'll learn next year. And it's one of them connects to the fibrous pericardium, and one is part of the heart wall, and the visceral layer is a part of the heart wall. And the pericardial cavity is a potential space. So that means that fluid shouldn't normally be there. You have a bit of lubricating fluid, like serous fluid, but otherwise it shouldn't be open. There shouldn't be other fluid under normal circumstances. Yeah, they're continuous structures, and yeah, expansion. And this is an example of what happens when you have excess fluid in those areas. So when you have cardiac tamponade, that's when you have excessive fluid in the pericardial cavity. And what happens is, because that's affecting the pericardium, you're going to get the phrenic nerve pain. And Beck's triad is a nice little three cardinal signs of what cardiac tamponade involves. That's hypertension, muffled heart sounds, and elevated JVP. The heart wall. So epicardium is the same as the visceral layer of serous pericardium. Myocardium is thickest, and endocardium, just like the rest of the blood vessels in your body, is simple squamous endothelium. You would have probably done different types of musculature to death, but just a reminder, cardiac muscles are striated and branching, and they have intercalated discs which allow the myocardium to contract as one, as a coordinated syncytium. And there's special types. There's also the trabeculate carne and the pectinate, which I guess increase the turbulent flow, which I guess sounds a bit counterintuitive, like why would you want turbulent flow? But if you have, if you don't have these things, then you can cause stasis of blood in your atria and ventricles, and that can cause emboli, and that will cause things to spread all over your body, so you don't want that. So you have those things to prevent that from happening. You also have the moderator band, which is slightly less important point, but it's part of the conducting system, and that moves conduction signals straight from the IV septum to the anterior papillary muscle. This isn't too important either. Just making sure that you know that this like anchors the myocardium and valve cusps, and it creates electrical insulation so that you don't have, I guess, APs firing all over the shop. The pericardial sinuses. So the transverse pericardial sinus is essentially when you have the atria folding up and above the ventricles, and you have that space between them with the inflow and outflow tracts right there, you can see. And that's where you ligate the vessels or block them off when you're having surgery. And the oblique pericardial sinus isn't too important, but it's imaging. It's a point of reference for imaging. Any questions at all? Anything I've covered? Huh? So, coronary arteries. So they start, as I said before, from the left and right cusps of the aortic valve, and they're fragile, so they can't be open during systole, because systole is an area of high pressure. So during systole, the cusps open and they block the openings to the coronary arteries to prevent that high pressure from affecting the coronary arteries. And during diastole, you have relaxation of the ventricles. So you have decreased pressure, and that kind of moves the cusps back in towards each other, so it prevents backflow, and also allows for the blood to reach the coronary arteries. So that's when you have the filling of the coronary arteries. B? Gun. Which one's a widowmaker? E? Yeah? Very good. Because it, as I said before, because it innervates more of the IV septum, it interrupts the conducting system more. So that's going to be the widowmaker. It's more deadly. D? Well done. B? Well done. All right, so right and left coronary arteries. You have, as indicated just before, the SA nodal artery is mostly from the right coronary artery, may vary though. Things to know about the arterial vasculature is that it can be very variable, so just note of that. And make sure you know the posterior interventricular and the left anterior descending very well, because those are the most important. Yep. That's just a nice diagram of where each thing is. Yep. And that's a decent image of what supplies what, but I guess it's more important to, I guess, know what coronary artery supplies each branch, and if you know the descending arteries or the interventricular arteries, will be mostly fine. Some more images. All right, so if you have a left dominant heart, then that's a huge problem because, as you said before, the left anterior descending supplies the anterior 2/3 of the IV septum. And if that occurs and it's left dominant, which means the left coronary artery supplies the posterior descending as well, that means that the entire IV septum is supplied by the left coronary artery. So if you have an occlusion of that artery, it's the most fatal AMI you can have because that cuts off the entire conduction system through the IV septum, which is like left and right bundles, right? Bundles of His, and therefore you won't have any conducting at all, and it's a massive problem. Right dominant hearts are the most common in amongst the population, 80% of cases. And codominance is when you have dual supply from both the right and the left. Yeah, and distal infarctions obviously are going to be less damaging than proximal infarctions. That's just an example of both. Venous drainage, less important, but just a few. Note the most important ones. So the coronary sinus. I hate the word sinus. It's a shit word. Like you can have sinuses here and here, but you can also have a coronary sinus, which is a vein, which drains essentially all the blood, deoxygenated blood from the heart straight into the right atrium. Doesn't have to go through the IVC or SVC. And you have three major veins. The great cardiac vein runs with the lad artery, middle cardiac with the posterior interventricular. Those are the most important points. I'm not these images, sorry. There it is. Very good. So blood vessels, you would done a histology crack on this. It was shit. Layers of blood vessels, having the tunica tissue externa at the end, at the very external surface, tunica media in the middle of swimming muscle, and tunica intima of the simple squamous endothelial cells, like the heart. And in large conduit arteries, like the aorta and things like that, you've got the vasa varosum, which is small blood vessels that supply a big blood vessel, which sounds weird, but that's how it works. Yep. Big? Very good. So knowing that, am I going too fast, by the way? Or is that okay? So arteries and veins, knowing the main differences. So arteries are low compliance. Veins are high compliance, so that means they stretch more when you have the same amount of pressure. And the arteries are a pressure reservoir. So as you said before, the arteries are resistance vessels and they help control the blood pressure via sympathetic innervation. And the veins, because they have a high compliance, they are a volume reservoir. So they have more of the blood in the body. And as you see here, the thick tunica media in the arteries, thin tunica media in the veins. Yeah. So arterioles, there are only one or two layers of discontinuous smooth muscle, and because they're discontinuous, they can act as sphincters. So that's the blood pressure control I was talking about before, and they're innervated by sympathetics only. Whereas the only exception to that rule of the entire cardiovascular system is supplied by sympathetics only, except for the penis or clitoris or the heart, which has both. Capillaries. You have three different types: continuous, fenestrated, and sinusoid, in increasing order of how holy they are, I guess. And obviously the main function is diffusion, and they have the highest surface area to volume ratio for that purpose, obviously, to diffuse. And if you have continuous ones, you have an uninterrupted endothelium, so that prevents things from going across. So that's the blood-brain barrier, things like that. Fenestrated and sinusoidal ones have holes in them that allow diffusion. So you have the small pores allowing serum proteins in the fenestrated and intracellular gaps and an incomplete basement membrane for white blood cell and red blood cell diffusion. Branches of the arch of the aorta. It's pretty much the same except for the brachiocephalic artery. That's the main difference. The common carotid and the left and the subclavian come off both on either side, obviously because you need subclavian vasculature and carotid vasculature on both sides. The only difference is that the brachiocephalic artery is that first branch on the right-hand side. And other than that, that's how it goes. I don't think you need to know much more than that. Do I need to know much more at this point? No. So, yeah. Innovation. So this is a fun little bit. But if you break it down, it's nowhere near as hard as you think it is. So main points. Parasympathetic is innervated by preganglionic vagus nerve fibers. Sympathetics are innervated. They start from T1 to T5 because the sympathetics in the brain, in the spinal cord, only start from T1 to L2 or L3. So you can only start from this area. Once you start here, you go up into the cervical sympathetic ganglion, and then from there you go postsynaptically. You synapse there. You go down to the heart. And that, because the heart started in the neck, that's evidence of the embryology that it's moved. The cardiac plexus is essentially just both sets of autonomic nerves coming together. And the parasympathetics come in preganglionically, if that's even a word, from the vagus nerve, and the postganglionic fibers pass through because they've already synapsed. They can go straight to the effector organ. Yeah. And that's a quick little summary table. Important point to note is that the parasympathetics only innervate the SA node and AV node. They don't innervate the ventricles. So they can't have an effect on contractility, whereas the sympathetic fibers can, and they innervate the entire heart, essentially. That's just a little schematic of what's happening there. Don't freak out over like neurology. It's fine if you just break it down. And yeah, so it makes sense that you need some kind of relay system to just modulate how the heart's going. So the autonomic control doesn't start it, start the heart pumping, because the heart pumps by itself. You have the SA nodal tissue and stuff like that simultaneously generating APs. So you don't need to start it. You need to just change how hard it pumps or how quickly it pumps. So at rest, you have dominant parasympathetic drive, which kind of lowers the heart rate. And information about your body essentially is relayed to the medulla in your brainstem. And the cardio-inhibitory, which makes sense, is the parasympathetic system, and the cardio-acceleratory is the sympathetic. And it has various synapses here and there. And that's an image to scare you, but essentially what I've just told you in those highlighted points is the same as what you need to know for this diagram. So this is here to show you, because when I see a diagram like this, I freak out and I'm like, what the hell's going on? Don't freak out, just break it down to the key points and you'll be fine. Back. All right, how am I going for time? No, not too bad. Question? See? Perfect. All right, so very simple. The vertebral column is has all those features. There's an alternating pattern of lordosis to kyphosis, and the sacral vertebrae and costal vertebrae are fused respectively as sacrum and coccyx. Yeah, so scoliosis is when you have abnormal lateral curvature of the spine, whereas with kyphosis you have outward curvature. And that's a primary curvature that you form before birth, whereas lordosis is inward curvature, so like this, pushing your stomach forward kind of thing. And that's developed post-birth because of walking and things like that. And stupid way I remember it is this stupid man. So if you remember, just find the way that mnemonics work is essentially just try to, like there are some like clear-cut ones that you can always remember, but the weirder yours are, the more personal they are, the better you'll remember them. So try to make your own mnemonics and you'll remember things fine. Spinal movements, you would have done this in back and thorax. So this is a very mobile patient, obviously. So you got flexion greatest in the cervical spine, extension greatest in the lumbar spine, lateral flexion extension in the lumbar spine, and rotation mostly in thoracic. And just knowing which one has the greatest movement in each movement, which area of the spine has the greatest movement in each area is important. And the cervical spine does everything. The thoracic spine does rotation only. So that's when you do arms across chest and you get into twists. And this all correlates with the clinical skills that you will have learned already. And lumbar spine is everything except for rotation. It does a little, but like that's pretty significant. All right. B? Sure. D? There we go. So, vertebral bodies, vascular trabecular bone enclosed by compact cortical bone. And the IV disc is probably the most important point of this slide. You are most susceptible during flexion because if you flex your vertebral bodies forward, you're going to force the things backward, right? So it's going to cause backward force and herniation backwards. And you may think it's posterior, but it's not because you've got the posterior longitudinal artery that protects, not artery, posterior longitudinal ligament that protects it perfectly posteriorly, so herniates on either side. And there's two parts of it, the annulus fibrosus and the nucleus pulposus. Annulus fibrosus is the outer bit, the fibrous bit, as the name suggests, and it's concentric laminae running obliquely, so that increases the protection it gives. And the pulposus is mostly avascular and watery. Landmarks. Just learn to know to identify each of these ones, because I think it's pretty likely they're going to ask you a question about, they're going to give you an image and be like, okay, identify this structure, or like from which vertebral level is this from? Like, is it thoracic spine, cervical spine, blah, blah, blah. So as long as you recognize most of these landmarks, a little mnemonic I like to know is pedicle. So pedicle and lamina are quite similar in that they're like part of the foramen, but the pedicles are proximal to the vertebral body. That's a nice little mnemonic. And in all of the slides, or in most of the slides, I've got notes underneath. In PowerPoint, you've got the notes kind of presenter slides kind of thing. I've got notes in all of those, so you can have a look at those if you want. This is a nice little summary table of each of the things. Knowing the important things that I've highlighted in red are the shape of the vertebral bodies. And it's really easy to remember because circular for cervical, so C and C, thoracic heart shape, because you've got the heart and thorax, and you've got the kidneys in the lumbar spine. So that's the K. That's kidneys. Transverse processes, you have transverse foramina in the cervical spine, you don't have anywhere else. In the thoracic spine, you've got the transverse costal processes, transverse costal facets for the ribs, obviously, and spinous processes, bifid and short for cervical, long for thoracic, and hatchet shaped for lumbar. And there's just some nice images going through. And note the uncinate process, which creates a kind of concave shape to the cervical vertebrae. Hopefully these images are quite clear. They're pretty self-explanatory. If you just go through them, you can make like an Anki card, like block out each one. Yeah. So the atypical cervical vertebrae, atlas has no vertebral body and no spinous process. The odontoid process is the most significant part of C2, the axis, because it projects superiorly and it essentially replaces it. So that you can think of it like that. And the vertebral prominence is kind of the atypical one because it has really small transverse foramina. And the spinous process is very long and it's not bifid either. The thing is, with a lot of these, a lot of the ones on the borders, so like C7 or like T1 or things like that, they share a lot of features from the spines that are adjacent to them. So obviously, vertebral prominence is going to be abnormal, and you'll find that's a running thing. And that's some nice images. All right, so you've got the thoracic vertebrae now. Note the superior costal facets and the transverse costal facets as well on the normal ones. So normally you have kind of demi-costal facets, so that includes that allows ribs to sit between kind of vertebral bodies. Whereas for T1 and from T10 to T12, you have complete costal facets. So on these ones, you have a superior costal facet and inferior costal facet. This mouse work? Yeah, so here and here. So a rib for here would sit. Its inferior border on that one, and then it's gonna have the rest of its head on the inferior costal facet of the superior vertebrae. Whereas these ones have a complete one just for the head. And T11, T12 don't have any transverse costal facets, and T12 is most commonly fractured. Okay. Yeah, these ones, sacroforamen allow for ventral and dorsal rami to exit, and the name's a bit confusing for the sacrum. So the sacral base is actually at the top, and the sacral apex is inferior. You would expect normally the base to be down, but it's because it's the flattest area. Yeah, those are some landmarks. This is the pars interarticularis. That's when it becomes important. When you have a fracture, and that allows for the vertebrae to slip forwards, you have spondylolisthesis, and that most commonly occurs at L5. Muscle of the back. This is pretty low yield. Just remember the main points that I've highlighted here, and it's pretty easy to remember in that superficial. Just think of it as superior and inferior. Superficial is upper limbs, intermediate is ribs and respiration, and deep is posture and spine and head as well. The dorsal rami are the only things to innervate the intrinsic muscles, and don't really innervate anything else. And yeah, cool. Just speed up. See, yeah, I heard that. Sweet. Spinal ligaments, knowing anterior and posterior are relative to the vertebral body. I'm going to have to speed up. I'm running out of time. Supraspinous is on the apex of the spinous processes. Interspinal is along the length of the spinous processes. And yeah, some extra ones that you may not know about. I didn't know about them. Nuchal ligaments for the cervical spine. And that's it there. Spinal nerves. So the conus medullaris is the end of the spinal cord, and it's more to note that it ends at L1, L2. Chorda equina is just the extension of the spinal cord after that, and it's just all spinal nerves going down, sacrum and everything like that. Knowing how they're named relative to C8 is important as well. Yep, so the lateral horn is where you have, you will know ventral and dorsal very well, but the lateral horn is where you have the sympathetic fibers. So that's from T1 to L2 and T1 to L2 and L1 and L2, and that's where the sympathetic fibers come out. Yeah, so this is just like the kind of terminology that you need to use. So ventral root and dorsal root come towards together and become a spinal nerve, and that ends up splitting into a ventral prime ramus, dorsal prime ramus, etc. And this is a lovely diagram that you would have seen already. It's actually a great diagram. Just knowing, I've got a note underneath this slide if you want to read those. But yeah, dorsal prime ramus is a lot bigger in this picture than it normally is. And yeah. This is pretty low yield. One anterior spinal artery, two posterior spinal arteries. There's 3 and 3 for spinal veins. And the internal vertebral venous plexus is valvus. That's important. And that exists in the epidural space, so outside the dura. And that's how a lot of metastatic cancer is going to rise because of the valveless nature. Because valves prevent the only allow one-way flow, right? If you have a valveless structure, you can move metastatic cells from the deep pelvic veins, like in the prostate and things like that, up and into your vertebrae, causing metastases in the spine. Meninges, dura mater, arachnoid mater, PA mater. Dura mater is tough. Arachnoid mater is flush against it. It's avascular and it's a lot thinner. It's next to it, but it's not connected. And it's flush because of the CSF pressure pushing upwards or outwards. Pia mater is thin and transparent. And it's tightly adhered to the brain. So if you dissect it next year, or when you dissect next year, you'll see that it's directly on it. It's hard to remove. These are some spaces. Epidural is where you have the internal venous plexus. Subdural is a potential space. And subarachnoid space is CSF and the target for lumbar punctures. And that's a nice diagram again. Herniations, it's a bit later, but posterolateral herniations, as I said before, in spinal flexion. And this is a weird rule. Herniations will affect the nerve root below the level of the implicated IV disc. So you have here herniation between L4 and L5, and you expect that the nerve that comes out at that level between L4 and L5 is the L4 nerve. But it typically arises above the IV disc, so that's why you impinge the nerve on the level below. So between L4 and L5, you have the L4 nerve, but an IV disc herniation between those two areas will damage the L5 nerve. Does that make sense? All right. Very simple. Thoracic outlet syndrome. There's three types: neurogenic, arterial, and venous. It's not really. It's a bit of a misnomer because it's between like the first rib and the clavicle. Not really thoracic, but anyway. You can cause it by having things like a congenital cervical rib, which is mostly asymptomatic, trauma to the clavicle, first rib, etc. And the symptoms that you get correlate with the type and the symptoms that you get and the structures that are affected. Sorry. There's two ways of classifying ribs relative to the sternum and vertebrae: true ribs, false ribs, floating ribs. Sternum. Most important point is the sternal angle, or the angle of Louis. That's an important landmark because that's where you palpate to see the second rib. It's also in line with the T4, T5 IV disc, and it's from the second rib to the T4, T5 IV disc that you have the transverse thoracic plane. Mediastinum, another fun one. You have the superior and inferior mediastinum, but the inferior is split into three: the anterior, middle, and posterior. And you have to know the structures that are in each one. And it may seem like it in this image that it goes through everything, but it's only in the midline, essentially. You have the lungs on the other side. It's fine. And the way to remember, this is an important one because it's important to know the structures that happen at each, or the things that happen at each level. So you have the mnemonic vat plant for the things that happen at that level, and that's an image of the things that happen at that level. These slides I've designed as more notes than kind of presentation slides, so you can review most of what you need to know. So I'm sorry if I'm rushing through this. And that's labeled diagram. So that's kind of the things that you should know, and that's labeled diagram. Concept of the mediastinum. I think mostly at this point in time, you would have covered this in anatomy. So you should know most of these things. But if you really want to know the important things, focus on the CVS kind of structures, and there are other important structures like the trachea and esophagus. And the thymus is the only thing in the anterior mediastinum. That's easy to remember. Yeah. Cool. That's a decent one from Teaching Me Anatomy. Diaphragm. Right hemidiaphragm is higher in the liver, due to the liver. It's skeletal muscle, so you can control your breathing. Innervated by phrenic nerves. Yep. And there's the hiatuses, and the mnemonic that you probably would have been told already is the vertebral level that it's at corresponds to the structure that's going through it. So vena cava, 8 letters, T8. Esophagus, 10 letters, T10. T12 is the aortic hiatus. That's perfect. Yep, knowing what runs through each one. And these are the arcuate ligaments of diaphragm. Probably less lower yield, but yeah, it's there for you. I'm going to skip ahead. See? Hey? Yeah. Yeah? Makes sense? It's the next slide, don't worry. External intercostals, hands in pockets, internal and innermost, hands on chest. And that's the way you remember how the fibers run. The internal are perpendicular to the external, and the external ones, they're outside to elevate, whereas the innermost and internal depress, and they're inside. Neurovascular bundles, the main intercostal nerve and stuff run in the subcostal groove in the inferior aspect of each rib, and the collateral branches are on the superior margin of the inferior rib. So with 2 different applications, you want to target 2 different things. So if you're having an intercostal nerve block, you actually want to hit the nerve, right? So you aim for just under each rib, and that's going to hit the nerve. Whereas if you're doing a thoracentesis or pleural tap, you're trying to remove fluid and you're trying to avoid damage to the nerves, obviously, right? So you want to aim for the superior margin of the inferior rib, because that, like, collateral branches can regrow, that's fine. And they're not as important as the main intercostals. Yep. And just knowing it's mid-axillary line intercostal space. Lower yield, but they're kind of in the same plane or continuations of the innermost intercostal nerves, muscles, sorry. Phrenic nerve damage, normally your diaphragm moves inferiorly and laterally when you breathe, but when you have unilateral phrenic nerve damage, the injured side's going to be higher, because just say this is damaged, this side's damaged, so it can't go down when I'm inspiring. The functional side pushes the abdominal contents down, and it's going to push, it's going to be, this isn't going to have much tone, right? So if you push this down on this side, it's going to go up on this side. Make sense? Cool. Intercostal arteries, thoracic aorta is most of the posteriors, and internal thoracic is most of the anteriors. Anterior intercostal veins. Yep. So anterior intercostal veins drain the internal thoracic vein like the arteries, but the posterior system is the ascus system, and that's mostly, you'll learn that next year mostly. And how not, it took me like 10 minutes to get it perfectly aligned, but like, look at that. How good is that? Yeah, so that's the end of my presentation. You guys are great. So it's been a pleasure to be your convener this year. You're a great group. Look after each other. If you need any help, message me or whatever. Message your friends. If you need, like, if you're really struggling, talk to a counselor or something like that. There's no shame in doing that. You're a great group, and it's been a pleasure to be your guys' convener this year. So good luck. Also, treasure next year, because next year is like the last year that you'll be all together, and like next the year after, in year 3, you're all spread apart. And also next year doesn't count, so just like relax and just like enjoy uni for what it is. Right? This is next year's your only proper uni year. After this year, of course. So enjoy that. Make sure you have a great time, and keep in touch. What are you
good. Good job.
What are you doing? You doing cardiacs?
Yeah, so it's really good because you went over all the yeah, and like I was gonna do like the anatomy of the vessels and shit, and you did all that.
Yeah,
Absolutely perfect.
Yeah, because like I was like a lot of the stuff I was tempted to like overlap, so I didn't do the conducting system at all, like SA no.
Oh, okay, yeah, that's
but
right.
since the revision lecture, I assumed that like they would know a good baseline.
Yeah, no,
and
that's totally true.
Yeah.
Yeah.
Hopefully I didn't miss too much.
No, you were perfect. Do you know how to get to it though?
Did you upload to the?
Yeah, to the drive. Oh, is
Okay.
it just on the?
Yeah, it should be if you log in. Wait, maybe not, because if you log out, wait, right, just give me a sec. How did you want to access it? Through Google Drive?
Yeah, sure, I don't mind.
Okay. Is there a way of accessing Google Drive while we're in live nets? Yeah.
Oh, awesome, thank you.
What's the presentation today?
Kate's going after me, and then it's Andrew Kawhi.
Is that it?
I think so. Yeah, it's only 4, so it's to finish early. Fucking swear.
I got a new phone recently because I had my old one replaced and I had to reset the fucking thing.
Oh my god, that was the biggest nightmare. I couldn't figure it out. Well, eventually I did, but that was such a pain in the butt.
I did it before the written lecture yesterday, and I was on hold for half an hour, and I fixed it within a minute. All I did was reset the fucking password. No,
that is tragic.
So, good luck.
Right here?
Oh yeah, shit. Is Chris like showing up?
Like he said, he was coming to mine. Yeah. So far, I don't see him.
Did he message you?
So no, he messaged Manoj and Karan, and they messaged me. Them was like, "Hey, just a heads up," and I was like, "He's joking." So he's gonna walk in any second, I swear. Thank you. Okay, can everyone hear me? Yeah? Awesome. Okay, so is Chris right here? Prof, right? No? Okay, well, he should be coming any second, so that's going to be fun. Okay, so my name's Jamie. I am a second year medical student, and welcome to Cardio Phys. So feel free to email me if you have any questions afterwards, or even better, email Prof Wright because he is the expert. So just some acknowledgements. And this is just an overview of what we're going to go over today. So I just wanted to say as well that the things I won't be covering will be the vascular endothelium, coronary circulation, health and disease, and the head up tilt or exercise practical. They've got pretty comprehensive notes, so you can go over that in your own time. So before we start, I just wanted to give you guys a couple of tips coming from an old second year medical student now. So just these are some of the things that I wish I'd done earlier and I feel would be really good for you guys to implement before you start your real system learning. So cardio is the first real big system you guys are studying, because let's be real, MSK isn't really a system. But cardio and all the systems that you follow on from are going to be amazing learning experiences and ways to hone in your study. So just some tips that I found really helped my system learning was to find some anatomy textbooks that you like. Don't underestimate the importance of a really good textbook. So personally, I like Gray's, but you can have a look at Moore and Daly's or Netter's or whatever you feel comfortable with. The second tip I have is to actually prepare for anatomy. So this was something that took me until second sem of this year to actually do. So sitting down on a Sunday and spending a couple of hours just going through specimen questions, watching the dissection video, and just doing a bit of reading for like the topics of that week is so helpful, and something I literally only started doing this semester. So if you guys can get in early, it's really good. The other thing is just to keep running notes. That's pretty logical, and to logically divide up your system. So, have a section for anatomy, phys, pharm, path, all of that. And then lastly is to not underestimate, is to not underestimate the value of group study. So I only just found an amazing study group that I study with weekly, and I wish I had started studying with them earlier back in Sem 1 and last year as well. So having a really good study group where you can just bounce ideas off each other, just like 3 or 4 of you, is an amazing, amazing thing. Okay, so let's get started. So the cardiovascular system, you guys should know this, comprised of 2 circuits. You have your pulmonary circuit, which goes from heart to lungs to heart. And this is a really low pressure system as well. And then you have your systemic circuit, which is going from heart to body to heart. And this is a high pressure system because there's a lot more distance to cover. So the heart needs to pump with a lot more pressure to kind of try and cover that distance. And it's also why the left ventricle is so much thicker than the right ventricle, because the left ventricle has to pump with that greater force to be able to pump the blood all the way around the body. Cool. So talking about blood flow through vessels now. So this is the first big kind of physicsy concept that you've got to understand about the circulatory system. So flow is determined by difference in pressure. Keep that in your head. So flow occurs from a region of high pressure to a region of low pressure. And then the other thing to know is that flow is directly proportional to the degree of difference in pressure. So if you have more pressure difference, then you're going to have more flow, and vice versa. And also this relationship is assuming like laminar flow. So if you have like a stenotic valve or a leaky valve, these same relationships don't apply. Cool. So the second big concept to know is resistance. And this is pretty much just how difficult it is for blood to get from point A to point B. So there's a couple of important things that determine resistance. So the first one is length. So if you have a greater length of a vessel, you're going to have greater resistance because there's a greater degree of friction that the blood is going to be encountering along that length. The second big thing is diameter, and arguably this is the most important physiological determinant of resistance because really small changes in radius confer massive, massive changes to resistance. And this is kind of shown by this equation here. So if you change the radius by a factor of something, then that something is put to the power of 4. So you can see that really small changes in diameter confer really big changes to resistance. And then lastly, there is viscosity. So usually it's kept quite constant. However, like in disease states such as dehydration or anemia, where your hematocrit can kind of go up or down, then the resistance might change, not the resistance, the viscosity might change a little bit. Also, Prof. Wright, if anything I say is wrong, feel free to interject at any time. Cool. Okay, so last big thing we got to know is compliance. So this refers pretty much to the ability of a vessel to withstand changes in pressure. So pretty much if a vessel is more compliant, then it's able to more easily adapt its volume to a change in pressure. So this is similar to veins. Veins are very highly compliant. Whereas in contrast, if a vessel is less compliant, then it's not able to change its volume so much for a given difference in pressure, for a given change in pressure. So that's something like arteries. So arteries are stiffer, which makes them less compliant, and then veins are less muscular or more stretchy, which makes them more compliant. Okay, so we've talked about compliance. V0 and the unstretched volume. Oh. Right, I haven't talked about that, but that's actually a really good point to go over.
So is it no, the pressure of the vessel doesn't increase. You fill it up first.
Yeah.
And then once you've got it filled beyond its normal shape, then the pressure starts going up.
Yeah, and you used a really good example of like a balloon. So if you have like a plain floppy balloon and it's not filled with anything, then there's no pressure inside it. If you blow up with the balloon with a little bit of air to just kind of give it just a little bit of shape, but not to actually stretch the walls, then that's going to be the unstressed volume. And then finally, once you start stretching the walls a little bit, you get the stress volume. So that's also a nice difference between how to kind of think about compliance and veins are sort of like that balloon with an easier compliance and an easier stretchability of the walls. Cool. So putting all of those concepts together, we get the flow equation. So we have flow equals change in pressure over radius, and over resistance, and yeah, really handy equation. Keep that in the back of your mind for the exam. Okay, so first question. Which of the following is true in relation to the following scenarios? And there's more than one answer. Sorry. Okay. Any hands up for A? Hands up for B? Hands up for C? Hands up for D? Hands up for E? Hands up for no idea. Okay, so the answer is actually B, C, and D. So the way you kind of work through this is you have a look at the difference in pressure. So we can see that the difference in pressure in vessel 1 is 40 milligrams of mercury. In vessel 2, it's 80, and in vessel 3, it's also 80. So this difference in pressure we talked about is directly proportional to flow. So what we can assume is that the flow in vessel 1 is going to be half that of those in vessel 2 and vessel 3. So these two vessels here are just kind of here to trick you, because even though this one has a higher absolute pressure at 90 milligrams of mercury, this one has a higher absolute pressure at 180 milligrams of mercury, it doesn't mean the degree of flow is greater, because the difference in pressure between both of those vessels is both 80 milligrams of mercury. So what that means is that you have the rate of flow in vessel 2 is twice that of vessel 1. That's true. The rate of flow in vessel 3 is also twice that of vessel 1. So that's also true. And then the rate of flow in vessel 2 is the same as in vessel 3. So that's also true. Does that make sense to everyone? Yeah? Cool. All right, question 2. This is a bit of math, I'm sorry. But if blood flow through a vessel is 100 mil a minute and the radius is increased by a factor of 2, what would the new flow be, assuming that the change in pressure remains the same? Arithmetic. Yeah, true. True. It's for the people who are awful at maths like me. Okay. Any takers for A? You guys still working? Any takers for B? C? Any D? Good job. A. Yeah. Fantastic. So there's just some attempted math for you, attempted arithmetic. But yeah, that's basically just to show that what I was talking about before, that increasing the diameter will increase the flow like massively. So increasing it by a factor of 2 will actually increase the flow by a factor of 16. Alrighty, next bit, excitation of the heart. So just starting, this should be pretty familiar, I think, to you guys, but basically we have our action potential starting up in the sinoatrial node. The wave of excitation spreads through these internodal pathways and through the AV node. It goes into the bundle of His, down into the Purkinje fibers, and then the entire heart contracts. So I have a question for you guys. So you can kind of see that there's all these numbers around here. So like this is referring to like the speed of conduction. So you can see that it's pretty fast around the atria. So we have like, 0.3, 0.4, 0.7, all that stuff. And then all of a sudden when we get to the ventricles, it's like, 0.16, 0.17, 0.21. So like the question I want to ask you is, why is the conduction through the AV node slowed? So why does it all of a sudden get real slow here? Anyone know? Any takers? Am I going to have to pick someone? Oh, yes. Why? Yeah.
Is it so that the atria acts before the ventricles rather than the
Yeah, I guess that's part of it. Yeah. Well, like the main big reason is to allow for the ventricles to have enough time to fill. So we have this deliberate slowing of the conduction through the AV node in order to give the ventricles enough time to fill before they contract. Or otherwise you'd have really crappy cardiac output. Does that make sense to everyone? Cool. Next bit, cardiac action potentials. So pretty much there's two types of action potentials that can occur within the heart. So we have our ventricular action potentials, and these are the ones that occur within the actual cardiac muscle cells. And then we have the pacemaker action potentials, which occur within the actual pacemaker cells. So the ones within like the SA node and the AV node and all that stuff. So just to recap quickly, just action potentials in general, in case you forgot, pretty much we need an influx of sodium and calcium to get depolarization, and we need an efflux of potassium to get repolarization. So that diagram is just reiterating that here. So we have a big concentration of sodium on the outside and a big concentration of potassium on the inside, and a relatively big concentration of calcium on the outside compared to that of the inside. Okay, so going through ventricular action potentials from phase 0 to phase 4. So we'll go through each one of those stages in detail, and excuse my awful photoshopping skills. So phase 0 is pretty much when we have all of the voltage-gated sodium channels opening, leading to this massive influx of sodium and giving us this massive jump in action potential from negative 85 millivolts to 0 millivolts. So we just get this really big, rapid depolarization. So then phase 1 and 2. So now at the end of this depolarization, we have our sodium channels starting to close and our potassium channels starting to open. And what this does is this leads to like a tiny little repolarization that we see here in phase 1. But at the same time, we have the opening of calcium channels. And since we spoke about before that calcium wants to bring that membrane potential back up, we kind of have this tug of war situation going on. So we have potassium trying to bring the membrane potential down and calcium trying to bring it back up. And that's why we have this phase 2 plateau. Cool, and this is the big difference as well between cardiac muscle excitation and skeletal muscle excitation as well. So there's no really plateau seen here in skeletal muscle excitation. So that's something unique for cardiac excitation. So in our last stages, we have the closing of our calcium channels, which then allows potassium to dominate, dragging that membrane potential all the way back down to where we started. Cool. And there's just a summary for you guys. And I've also included a video in the comment section down the bottom, just to Khan Academy if you're still having a bit of trouble understanding that. Okay, so we've gone through ventricular action potentials. So now we're going to have a look at the pacemaker potentials. So these are the ones that are occurring within the SA node and the AV node. So these are slightly different from ventricular action potentials because they don't have a phase 1 or a phase 2. And it starts with phase 4, which seems really counterintuitive, but it does make sense, so bear with me. Okay, so going through these in detail. So our first stage, which is phase 4, we have this initial funny current, which is basically this really slow depolarization caused by like a mixed sodium and potassium influx and efflux. That should say /efflux at the end. So the reason why it's so slow is because it's similar to that tug of war situation that we saw in the ventricular action potential. So we have our sodium wanting to bring the membrane potential up, our potassium trying to bring it down. So what results is like this really slow kind of tug of war depolarization type thing.
I reckon the direction you made is really important to highlight again. You said it.
Yes.
It's sodium influx.
Yeah, potassium efflux. So
if you're reading that on Sunday night before the exam, just remember this. Just needs to be slightly.
Yeah. I'll fix that in the post slides as well. Okay, so we have that funny kind of depolarization, and then finally we have the transient calcium channels opening around the end, which kind of gives the action potential that little bit of a push to reach the threshold. So then once we've reached the threshold, then we can call it phase 0 because that's when our rapid depolarization occurs. So that's why phase 4 has to come before phase 0. So once that threshold is reached, we have that rapid depolarization because of the opening of latent calcium channels. And then after that, the potassium channels open, the calcium channels close, leading to the repolarization we see in phase 3, and then back to phase 4. Cool. And there's just a normal summary again for you guys. Okay, the ECG. So this is a huge topic and can be super intimidating in first year, but I'm only going to go over like the basics of it. You will learn loads more about it next year, but I just wanted to give you a few tips as well, just for.
Can I reinforce that?
Yes.
Right, you've got 5 years to learn how to read an ECG.
Yes.
And if you ever actually go to use an ECG, like as a cardiologist or anything, you've got another 7 years to learn an ECG.
Yeah. So
the idea at the end of year 1 you expect to interpret an ECG is nonsense.
Yeah.
That's what we're saying is absolutely correct. So people spend hours just going.
Yeah, exactly. So I think for year 1, the only one you really need to know is AFib. But yeah, I literally just started sort of understanding them now, and I'm already at the end of second year. So really don't freak out if you don't understand it yet. Just know how to read AFib. So the second tip I have for you guys is to actually go to Nadita's ECG revision lectures. She's an absolute legend and she goes over it in great detail. And then also just some resources. There's an awesome podcast called Humorous Hacks. They have this really great episode called ECG's Louise, and it's just a really fun and nice episode. It only takes an hour, so like pop it on when you're in the car or something. And there's also Life in the Fast Lane, which is a nice internet resource as well. Okay, so basics of ECG. What is actually happening? So just going over it systematically. So first, when we have this little flat bit of the ECG, that's corresponding to the SA node generating its action potentials. So the ECG is flat. So then when we have this first little blip, we have the atrial depolarization and contraction. So then back when it's flat again, we have the action potential passing through like the bundle of His, the AV node, the Purkinje fibers, all that. And then we get this big, massive peak in this fourth stage, which corresponds to the contraction, the depolarization and contraction of the ventricles. And then lastly, we have this final little blip over here, which corresponds to the ventricular repolarization. That's pretty much is what's happening in the ECG. So we can actually give like names to all these little blips. So our P wave is that little first blip that's corresponding to atrial depolarization. Our QRS complex is this next big blip, which is referring to ventricular depolarization. And then lastly, our T wave is referring to the ventricular repolarization. Okay, so that's all I'm going to go through with ECG for today. So now moving on to pacemakers of the heart. So we've looked at what's happened during one contraction of the heart, that complex of the ECG. And now we're going to look at how many times that contraction occurs per minute. So this is the heart rate or the beats per minute. So usually all of the pacemakers of the heart follow the pacemaker with the fastest intrinsic rate of firing. So in this case, it's going to be the SA node, which has about an intrinsic firing rate of 70 to 80 beats per minute, which gives us our sinus rhythm. And if you think of it kind of like a train, it makes like a lot of sense. So all the train carriages will follow the speed of the fastest train, so the SA node. Okay, so now that we know how pacemaking works, we can kind of predict what happens when stuff goes wrong. So things that can go wrong, we could have maybe a shift of the pacemaker from the SA node to like other pacemaking regions. So for example, if we have like ischemia causing, death of the SA node, and then that'll leave like the AV node to take over and set the intrinsic firing rate of the heart. That could happen. We could also have abnormal impulse generation from the SA node, leading to things like sinus tachycardia or sinus bradycardia. We could also have blocking or delay of the conduction of an impulse through the heart, so AV node block. And this is one of my favorites. It's really interesting because in AV node block, what happens is pretty much like the communication bridge between the atria and the ventricles is severed. So all of a sudden you have like this independent contraction of the atria and the ventricles, and the atria are just following the rate of the SA node at like 70 to 80 beats per minute, and then the ventricles are just contracting on their own at the rate of the Purkinje fibers at like 40 beats per minute. So it's a really interesting kind of case study. And then lastly, we can have spontaneous generation of abnormal impulses in any region of the heart, giving you things like ectopic beats or VFib. So just to go back over AV node block, so this ECG is just a really nice reflection of what I was talking about earlier, how you can see that really complete disconnection between all of the QRS complexes and the P waves. So this is showing that the ventricles and the atria are just completely contracting independently of each other. So yeah, it's pretty interesting. Cool, and then just looking at autonomic control of the heart. So Calvin went over a little bit of this before, but the main point I wanted to make with this is that the sympathetic nervous system can both increase heart rate and force of contraction, but the parasympathetic nervous system can only influence the heart rate and doesn't have much of an influence over the contraction. Cool, so questions. During exercise, the heart rate increases. Which of the following contributes to this rise in heart rate? So hands up for A, hands up for B, hands up for C, hands up for D, hands up for E. Okay, good job. So it's both A and C. So that's just going over what we looked at before. Okay, question 4. In relation to ventricular action potentials, which of the following is false? I'll give you guys a second to read through. Okay, any takers for A? Any takers for B? C? D? And E? And no idea. Okay, that's fine. So the answer is actually A. So this is a tricky one as well. So it's caused by the simultaneous opening of the calcium and potassium channels. So that was just a little semantic kind of thing. But all the rest are actually true. Okay, question 5. A man presents to the ED complaining of dizziness and chest pain. The ECG revealed an atrial contraction rate of 90 contractions per minute with a complete blockage of conduction through the AV node. What would his observable pulse rate be? Okay, any takers for A? B? C? D? Great job. Yeah, it's C. So just remembering that the observable pulse rate is going to be what the ventricles are contracting at, because they're the ones with enough strength of contraction to transmit like an actual force through the periphery. Great. Cardiac cycle and cardiac output. So contraction of heart muscle. So in terms of how the actual heart muscle contracts, it undergoes like a similar process to skeletal muscle with like the cross-bridge cycling and the excitation contraction coupling. But there are a couple of really big differences. So the first big difference is that the cardiac muscle can't undergo tetanic contractions, which is really important because if your heart undergoes tetanic contractions, you get, what you'd see in VFib, which is like your ventricles just like quivering uncontrollably and not actually pumping any blood out anywhere. So the ability of the heart muscle to contract ensures that we don't get any tetanic contractions. And that's because of this plateau phase. So it ensures that only one action potential can occur at a time. And then the refractory periods are kind of shown here. So the other big thing that differentiates the contraction of heart muscle from the contraction of skeletal muscle is this thing called calcium-induced calcium release. So basically, all calcium-induced calcium release is the fact that external calcium influx is required for contraction. So external calcium influx is necessary for the release of calcium needed for contraction. Does that make sense? It's a bit wordy. But I'll say that again just in case. So external influx of calcium is required to release the internal calcium needed for contraction. So that's all excitation contraction coupling is. And what it means is that excitation is always necessary for contraction. You cannot ever have contraction without excitation. So you need to have that initial excitation you need to have the initial excitation to bring in that calcium from the outside, which will then allow the calcium from the inside to be released and therefore induce contraction. It's a little bit confusing, but if you read through this process over here, and I've also got a diagram for like the visual learners, it'll make sense. You don't need to memorize every single step of it, but just knowing what the point of calcium-induced calcium release is and how it relates to the fact that we always need to have excitation before contraction. Okay, so cardiac output. So cardiac output pretty much just refers to the volume of blood ejected from the heart per minute. So it's calculated by multiplying stroke volume by heart rate, and therefore we can change the cardiac output by either changing stroke volume or heart rate. So just a quick note about what stroke volume actually is, because this confused me a little bit. So stroke volume is just the amount of blood ejected from the heart per contraction. But the thing you've got to keep in mind is that not all the blood within the ventricles is ejected every time the heart contracts. So that's why we need to subtract the leftover amount that's left at the end of systole from the original amount that was there at the end of diastole. So that's why your stroke volume is calculated by subtracting ESV from EDV. And there's just like a diagram to reiterate that. Okay, so how can we actually change stroke volume? So there's two ways we can do it. We can either we can alter the stretch, and we can also alter the contractility. So we'll just go over like the stretch part first. So changing stroke volume, We can do this by increasing the amount of blood in the ventricles. And that's because if we increase the blood in the ventricles, then we increase the pressure in the ventricles. And if we increase the pressure in the ventricles, then we stretch the muscle fibers more. And then if we stretch the muscle fibers more, then we can have an increased force of contraction. So it's kind of just like a logical flow. So this whole concept that the stroke volume can increase in response to a stretch in the ventricles is called the Frank-Starling law, the Frank-Starling mechanism. You also might see variations of the Frank-Starling mechanism saying that like an increased venous return will lead to an increased stroke volume, or an increased preload will lead to increased cardiac output and things like that. So what I want to say is that in this case, end-diastolic, preload, venous return, they're all really referring to the pressure in the ventricles. So they're all going to influence that pressure in the ventricles and therefore influence the cardiac output. So just don't be too confused when you see all those different words. And then again, that graph is just reiterating that relationship. So when you have increased atrial pressure, then you're going to have increased pressure on the ventricles, and then you're going to have increased cardiac output. Cool. So this concept of the Frank-Starling mechanism is also really important for this idea of automatic matching. So it means that the left and the right side of the heart will match each other's output in order to prevent congestion. And then there's just a diagram. Okay, so the other way that we can change... Yes.
So why would the right ventricular cardiac output go up? Question?
Any suggestions?
The venous return goes up.
Yeah.
Right, so the cardiac output equals the venous return.
Yeah.
And the mechanism you've described, the Frank-Starling law,
Yes.
which is how the equal sign works.
Yes. So I'm going to go through that in more detail afterwards as well, but that's exactly right. So some reasons why the right ventricle pressure might go up is if we have an increased venous return, so increased amounts of blood coming into the right atrium in the first place. Cool. So the other way we can change stroke volume is by changing calcium release, and this is going to affect the contractility of the heart. So this is done by increasing calcium concentrations, and a way that we can do this is through sympathetic activation. So the sympathetic nervous system will release noradrenaline and circulating adrenaline, and that'll act on the beta receptors of the heart, which will then increase calcium entry into the cell and increase calcium release from the sarcoplasmic reticulum. And there's a summary. Okay, so I'm not going to go through the cardiac cycle just for the sake of time, but basically the main thing to take away from the cardiac cycle is how the ECG and the heart sounds relate to all the different events that occur throughout the cardiac cycle. So if you go through this slide and this slide, it makes a lot of sense really logically, and if you like use the diagram as well to kind of go through it systematically, it makes loads of sense.
Wiggins diagram,
Wiggins diagram, yes. Yes. Yeah, it's really helpful. Okay, question 6. Which of the following is true of cardiac muscle contraction but not skeletal muscle contraction? So I'll give you a few seconds. Okay, hands up for A. Hands up for B. Hands up for C. Hands up for D. Hands up for E. Okay, good. So I saw a few answers for A, which was right. So the main differentiating factor between cardiac muscle contraction and skeletal muscle contraction is that you need external calcium to come in to influence that internal release of calcium. So that's the big key difference between cardiac muscle contraction and skeletal muscle contraction. Okay, which of the following would not increase cardiac output? Okay, hands up for A, hands up for B, hands up for C, hands up for D, hands up for E. Okay, good job. Yeah, so decreasing venous return will not increase cardiac output. It will decrease cardiac output. Okay, so this is prof rights domain, so feel free to interject at any time. I will do my best. Okay, so now we're going to be looking at the physiology of circulation and all the big physicsy kind of concepts. So just a recap of what we've gone through is these are things I want you to keep in mind when we go through the next couple of slides. So flow is determined by differences in pressure. Resistance is inversely proportional to flow. So more resistance equals less flow. veins are more compliant than arteries, and lastly, just keep those equations in mind. Okay, so first big thing that we're going to look at is pressure within the circulatory system. So this slide is basically just explaining some of the big key pressures within the circulatory system and kind of what happens to the arterial system versus the venous system when we move blood around between the two systems. Okay, so our first big concept is this thing called pressure mean systemic, or PMS. So this is the pressure within the circulatory system when the heart is not pumping. So it's basically just how full the circulatory system is. So when we were talking about that idea of unstressed volume versus stress volume, it's like that unstressed volume. It's how full the circulatory system is in order to give the veins some sort of shape, but not to actually fully stretch those walls. So next we're going to add in the heart. And what happens all of a sudden, we've got no heart when we're thinking about the pressure mean systemic, we're just thinking when the heart's not pumping, and now we're going to add in the heart. And what happens when we add in the heart, like pretty much essentially every time the heart pumps, is it moves a bolus of fluid from the veins and into the arteries. So that's basically exactly what the heart's doing, like every time it pumps. It's literally taking blood from the veins and putting it into the arteries and just going again and again and again and again. So when we take blood out of the veins, this will decrease the pressure in the veins, right? Yeah? And then if we put blood into the arteries, that means we're going to be increasing pressure in the arteries, yeah? So we're going to be decreasing pressure in the veins and we're going to be increasing pressure in the arteries. But the pressure in the veins is going to decrease less than the pressure in the arteries will increase. So I'll say that again. So the pressure in the veins will decrease less than the pressure in the arteries will increase. And that's because of this idea of compliance as well. So the pressure within the veins is going to drop less because the veins have a higher compliance. Whereas the pressure within the arteries is going to rise to a lesser degree than the pressure in the veins will drop because they are less. Did I misspeak? Okay. To a greater degree because they have lower compliance. Okay. So that's a bit confusing. Read over it a couple of times. If you want, go back to the lecture and like listen to me just like say that on like 0.25 times speed, just like a few times, and it will make sense. So we know that we have this difference in pressure occurring, and that if we have larger differences in pressure, which we're creating by moving the blood from the venous system into the arterial system, then we're going to have more flow, right? Because we said that greater differences in pressure are going to make greater flow. So then we have more flow, and then eventually the rate at which the heart is pumping is going to equal the rate that the blood is coming back into the system. Does that kind of make any lick of sense? Thanks. Okay, if that doesn't make sense now. Yep.
So you've got a paragraph.
Yes.
But the rate at which the heart is pumping blood out of the system, so how about we change that to the rate at which the heart is pumping blood into the arteries? Yeah?
Yep.
That puts the pressure in the arteries up.
Yep.
So the pressure gradient between the arteries and the veins out there in the body is increasing.
Yep.
So therefore the flow of blood coming back into the veins on the last slide.
Right, okay.
So the flow of blood out of the veins, which the heart does, pumps up the arteries.
Yep.
The artery pressure goes up, so it's easy to get into the veins. So eventually those two flows are the same. That's what you're saying.
Yeah, exactly. Exactly.
Correct.
Awesome.
Maybe just change those words.
Okay, cool. I'll have a play around with those words for you guys. But just read over this a few times. Just kind of sit there and just read over it and it will click. It clicked for me and it took me like 10 times to read over it, but it clicks.
Here is the model, right?
Yeah, there's a really, yeah. Did you show them the physiology model? Did you show them that? Did you show them that? Yeah, so that was a really, really good model as well. So rewatch that lecture as well if you want it to make more sense. So another way to kind of put it into perspective is to like think about like a patient in a state of sepsis. So in sepsis, you have really, really leaky vessels, which leads to a really low vascular resistance, right? They're really leaky, so there's going to be like no resistance basically. So what that means is if there's no resistance, there's going to be less of a pressure difference between the arterial and the venous system, which means that there's going to be less flow back to the heart, which means that the poor heart's going to have to pump like loads harder to try and keep the blood pressure up. So that's why when you have patients with sepsis, you see them have like ridiculously low blood pressures and their poor heart's just struggling because they can't keep that blood pressure up. And that's because with that lack of resistance, you have a really small difference in the pressure, so it can't flow properly back to the heart. That's another way of thinking about it clinically. Okay, so slightly more easier stuff. We're just going to look at each of the components of the circulatory system individually and how they contribute to all of these different pressures. So first we're going to look at arteries. So basically what arteries do is they allow for the blood flow to be continuous despite the intermittent flow of blood out of the heart. So if you think about it, the heart is only pumping a certain number of times, and in between the spaces of the heart pumping, like where is blood going to flow? If the heart's not pumping blood between each heartbeat, how is the blood going to reach the places where it needs to go? So the reason for that is because our lovely arteries actually use 2/3 of their blood to hold open their walls during systole. So when the heart is pumping and all the blood's flowing through really nicely, only 1/3 of that blood is actually participating in blood flow, and the other 2/3 are being used to keep the walls open. So that means in between our heartbeats, when all of a sudden we don't have this lovely rush of blood flow, that 2/3 that's being used to keep the walls open can actually now come in and participate in the actual blood flow. So this is ensuring that blood flow remains continuous despite the intermittent beats of the heart. And then using that, we can actually figure out why our systolic pressure is going to be bigger than our diastolic pressure. Because during systole, we're using so much more pressure to keep our walls open. So it's going to be around 120 millimeters of mercury. But then during diastole, that extra blood isn't being used to keep the walls open. So you're going to have a much lower pressure at around 80 milligrams of mercury. Does that make sense? Cool. Alrighty. So next big thing is the arterioles. We've done arteries and we're looking at arterioles. So the role of arterioles is pretty much just to control resistance by increasing or decreasing their diameter. So if you have contraction of arterioles, you're going to decrease their diameter and therefore increase resistance. And then if we have dilation of the arterioles, we're going to increase their diameter and therefore decrease the resistance. So there's a whole lot of ways that you can contract and dilate arterioles, and I've tried to summarize them in this table here. And yeah, you can read through that in your own time. Okay, role of capillaries and the lymphatic circulation. So pretty much blood capillaries, that's the next step down from arterioles. So they just allow for the exchange of substances between the interstitial fluid and the circulatory system. And then the lymphatic capillaries are kind of like the opposite. So they're kind of taking all of that fluid that's been leaked out into the interstitium and returning it back into the venous system. So Starling's forces. And this will come back to haunt you in renal. So I would advise maybe not know it back to front right now, but just have a little bit of an understanding of what this actually is, because this is kind of important in cardio too. So Starling's forces, what are Starling's forces? These are the forces that determine how much fluid is filtered out of the veins and into the lymphatics. So you have all your fluid circulating in the capillaries, and then it's determining how much is leaked out of the capillaries and into the interstitium. So there's 4 main forces involved, and they all sound the same, which is really annoying, but they make a bit of sense when you look at the actual wording. So we first have our internal hydrostatic pressure, which is the pressure exerted by the fluid in the capillaries. So if you think about it, if you have more pressure in the capillaries, then you're going to want to push fluid out of the capillaries and into the interstitium. Does that make sense? Cool. And then you have the opposite, which is external hydrostatic pressure, which is all the fluid exerted by the pressure in the interstitium. So if you have loads of fluid in the interstitium, then it's going to try and push fluid back into the capillaries. Yeah? Cool. Okay. So the next thing is oncotic pressure. Basically, all this is it's the pressure exerted by proteins within the plasma or within the blood or interstitium or wherever. And proteins like to suck fluid in. So if we have loads of proteins in our capillaries, then they're going to exert a really big internal oncotic pressure. They're going to try and suck loads and loads of fluids back into the capillaries. Whereas with our external oncotic pressure, if we have loads and loads of proteins within the interstitium, then it's going to try and suck fluid out of the capillaries and into the interstitium. So we can kind of break that down now into 2 kind of categories of forces. So the ones that favor filtration, so the ones that want to push fluid out of the capillaries. So we have our internal hydrostatic pressure, so the ones trying to push fluid out of the capillaries, and our external oncotic pressure, so the one the proteins outside the interstitium was trying to suck all the fluid from the capillaries. So that's really favoring like fluid going out of the capillaries. And then lastly, we have pressures that oppose filtration. So things that want to suck the fluid back into the capillaries. So that's the external hydrostatic pressure, which is pushing the fluid back in, and then the internal oncotic pressure by the proteins of the capillaries that are trying to suck the fluid back in. And the way I like to remember that as well is oncotic likes to suck. So just think about it that way. It's like, you have your proteins in your interstitium trying to suck fluid in, and your proteins in the interstitium trying to suck fluid out. Okay, I'll skip over this for the sake of time, but how on earth does this relate to the cardio system at all? The reason is edema. It relates because of edema. So what we can kind of think about is edema in terms of left and right heart failure. So if you look at left heart failure, this is basically a failure of the left heart to pump properly. So if the left heart isn't pumping properly and it's like, like kind of pumping just really crappy fluid all the way out into here, then you're going to have a backup of blood in the pulmonary system. If you have a backup of blood in the pulmonary system, we're going to have lots and lots of fluid inside those vessels. And like we talked about before, that's a really, really big hydrostatic pressure, right? So that's going to try and push fluid out of the vessels and into the lungs, which is not very good because then you get pulmonary edema. And then the opposite thing kind of happens in right heart failure. So if the right heart can't really pump into the pulmonary system, then all this blood's going to back up in the systemic circulation. Then you're going to have loads of blood inside your systemic vessels, and then all that loads of blood is trying to push fluid out because it's too full. It's, really big hydrostatic pressure. So then you're going to get peripheral edema. And that's how that relates. Okay, the role of veins. So we've done arteries, arterioles, capillaries, and now we've got veins. So the role of the veins pretty much is to provide a low resistance pathway because of its like high compliance back to the heart. So this is this concept that we call venous return. And in normal healthy individuals, the venous return is going to equal the cardiac output. Swap? Oh, yes. Equals venous return. Cardiac output equals venous return. Cool. Okay. So when I first encountered... So when I first encountered venous return, this was me. I didn't know what was going on. And I was just like, what on earth is this equation? But it's actually not so bad. So we'll break it down, and it's pretty chill. So how does venous return work, and what is this equation? So to start off with, we're just going to look at a couple of definitions. So PMS, pressure means systemic, it's what we talked about before, so how full the circulatory system is. Then we have pressure in the right atrium, which is usually approximately 0 milligrams of mercury. And then we have resistance to venous return. So in this equation, the two big ones I'll be focusing on is PMS and PRA. I'm not going to focus too much on resistance to venous return. So the main thing I just want to say to you is that the pressure gradient between PMS and PMA is the primary force driving blood back to the heart. So that makes sense if you look at this equation. So the bigger the gradient between these two things here, the greater the venous return, right? It's just maths. Yeah? Does that make sense? Yes? Any sense? Nod? Yeah? Okay. Cool. So therefore, we can say that if we increase our PMS, then we're going to increase this gradient. Yeah? And then therefore we're going to increase venous return. Then I ran into a little bit of a pickle, and I was like, wait a second, how on earth does PMS relate to venous return? Like, what? Where did that even come from? But basically, you've got to consider that the veins are the primary capitance vessels of the body. So they hold about 75% of the body's total blood. So therefore, they're going to have the greatest impact on the PMS because they're basically what make up the majority of the PMS. It like makes up 75% of the PMS. So that's what's going to have the biggest influence on the fullness of the circulatory system. So that's how venous return relates to PMS. Does that make sense? Yeah? Okay. So there are a couple of ways we can increase PMS and therefore increase our venous return. So the first thing is by sympathetic nervous system activation. So if we stiffen the walls of the veins, then we can increase the PMS. The muscular pumps in the skeletal muscles in your legs can also squeeze the veins, and that will also increase PMS. We also have this respiratory pump. So every time we inhale, our veins actually squeeze in our abdomen, and that's why like people like squat down and like like pretend like they're doing poo whenever they have like SVT or low blood pressure and stuff. So that increases PMS and increases venous return. And then the last way we can increase PMS is literally by fluid resuscitation, by actually injecting fluid into the circulation and literally increasing the fullness of the circulatory system. So that also increases PMS. Okay, so if we put that all together, we get the cardiac vascular function curve. So this is basically just a big kind of summary of like everything, really. So we're going to look at the cardiac function curve first in red. So this is just showing what we were just talking about before. So as end diastolic volume increases, so does our cardiac output. Pretty simple. Then we move on to the blue and have a look at what happens in sympathetic stimulation. So sympathetic stimulation shows that we're going to be increasing our cardiac output because we're going to be increasing our EDV. And then lastly, we can look at heart failure, in which cardiac output is decreased because we're decreasing our cardiac output for every increase in EDV because the heart's not really pumping very well. So then the next big thing that we look at is this opposite kind of line, which is the vascular function curve. So this is basically just showing what we talked about before. So if we go back to that equation, so VR equals PMS minus PRA over RVR. So keep this PMS minus PRA in mind. So if we increase right atrial pressure, so if we increase that, then we're going to be decreasing venous return, right? So that just shows exactly that pretty much. So as we increase our right atrial pressure, we're going to be decreasing our venous return. And then this line, this black line here, basically it's meant to represent PMS. So if we increase our PMS, we're going to be increasing our venous return as well. So if we pick like an imaginary like point of right atrial pressure, and let's say it's just 5, if we have our normal venous return, then it's going to be like, I don't know, around 2 and a bit. But if we have an increased PMS, then all of a sudden our cardiac output, our venous return is going to jump all the way up to 4 and a bit. So we can see how PMS increases venous return. Cool. And then these are just some situations that might happen and kind of shows how the cardiac function curve shifts in different situations. So like, for example, in sympathetic stimulation, we have this shift from red to blue. And then if we also increase the stiffening of the walls of the veins, then we can jump this curve from black to dotted line. So then we have a massive cardiac output and a massive venous return, and everything just increases, which is good in sympathetic stimulation. And then conversely, we can have something like heart failure where the heart isn't pumping properly. So all of a sudden we have this red curve shifting down into the green curve because just the heart, it's not pumping, it can't keep up with the demand. And what this does is it increases pooling of blood in the veins because the heart can't really pump it out properly. And interestingly, this shifts the curve as well from the solid line to the dotted line. So you have an increased PMS with heart failure. And this is exactly the opposite of what we want, because if we have all of this increased PMS, it's just going to get congested and lead to things like edema. So, you know, increasing PMS is good in some circumstances, but in things like heart failure where the heart can't actually keep up with the demand, it's going to be really bad because everything's just going to get really congested.
Just a quick clarification. If you look at the model, you've got the heart.
Yep.
What happens in heart failure is your body is under perfused, so the kidneys start to retain salt and water. That's how the PMS goes up in heart failure.
Right, okay.
If you just look at the model and the heart's pumping normally, PMS is 7.
Yeah.
Make it pump at 0.5, PMS is 7. Make it pump at 0, stop, PMS is 7.
Yeah.
So the heart, changing the heart pumping itself doesn't change the PMS. It's the body's response to heart failure which says, kidneys are not getting enough flow, I need to fill up the circulation up. So that's what causes that to go up.
Yeah, cool. Yeah, so that's exactly right. And as we said before, that's going to lead to lots of nasty consequences. So, question 8. Which of the following would decrease flow within the circulatory system? Okay. Hands up for A. Hands up for B. Hands up for C. Hands up for D. Hands up for E. Okay, good. So I saw a couple of B's in there, so good job. So just to kind of like a bit of a side note, just going over the contraction, what happens when we contract the arterioles and the veins. So the right answer back here, the right answer back here was that the contraction of arterial smooth muscle decreases blood flow within the circulatory system, because when we contract our arterioles, we're going to constrict the radius, we constrict the radius, we're going to increase resistance, and if we increase resistance, we're going to decrease blood flow. And interestingly, this is the kind of the exact opposite of what happens in veins, which this took me a long time to understand, but it's actually really cool and explains a lot. So the effect of sympathetic drive on the arterioles is to contract, but the effect of sympathetic drive on veins is to contract, but then that also increases blood flow, because if you contract the veins, you have increased stiffening of the walls. If you have increased stiffening, you get increased venous pressure, increased pressure difference, more venous return, and therefore more blood flow. So just remember and keep in mind that contraction of the arterioles and the veins will have different consequences.
And you get regional changes. So if you contract all your gut veins, what they call the splanchnic, the gut circulation, and all that fluid just goes into the other parts of your body. So the body can constrict some veins and not others, which is also why they can cause other changes.
Right, okay. Yeah. Awesome. Okay, so this is just kind of memory. So which of the following forces favor the filtration out of the capillaries? So hands up for A. Hands up for B. Hands up for C. Hands up for D. Great job. So it's A. That's memorization. Okay, and which of the following is false? A second. Hands up for A. Hands up for B. Hands up for C. Hands up for D. Hands up for E. Okay. So it's C. So your increased pooling of blood in the veins, so like I said before, it actually results in increased venous return. But that's not something that we want because the heart is already struggling to pump already. So if we have increased venous return but the heart that's not pumping very well, then we're going to have all that congestion. Okay, so last little bit is just regulation of blood pressure and how we can regulate it over the long term and the short term. So in the short term, we can control our blood pressure through rapid changes in like local vasodilation or vasoconstriction. And this is primarily through like baroreceptors and the baroreceptor reflex. And then our long-term control is the slow, controlled kind of changes in blood pressure that occur over weeks to months. And that's primarily influenced by the RAS system and the renal sodium blood pressure set point. Okay, so starting off with our acute control, basically the purpose of baroreceptors is to inhibit the vasoconstrictive area in the medulla, like Calvin talked about, and excite the vagal parasympathetic center. So if we're having inhibition of the vasoconstrictive center and excitation of the parasympathetic center, then we can kind of conclude that the whole point of the baroreceptors is because they want to increase the dilation of the vessels, which makes a lot of sense because if you have really high blood pressure, then you're going to stretch the walls of the vessels, which will signal to the arterioles that, not the arterioles, will signal to the baroreceptors that the blood pressure is too high, and the baroreceptors are like, oh crap, we need to inhibit that vasoconstrictive center and excite that parasympathetic center. So that's going to work to bring that blood pressure back down by dilating the vessels. So kind of the opposite thing that happens with baroreceptors is the baroreceptor reflex. And this is a really handy thing that happens in response to like hemorrhage or really low blood pressure when you go from like sitting to standing too quickly. So basically when you have reduced blood pressure and the vessel walls aren't stretching so much, your baroreceptors aren't going to fire so much. So if you have decreased firing of your baroreceptors, everything kind of goes, oh crap, we need some sympathetic activation. So the sympathetic nervous system kicks in. So basically inhibition of the baroreceptors kicks in the sympathetic system. So that's just what you've got to take away from that. And then lastly, we have our long-term control. So these are the things that control blood pressure over the long term. So the first big thing is the RAS system, and here's just the system here, but at the end of the system is aldosterone. So basically aldosterone works to increase sodium retention and therefore water retention because water follows sodium. And if you have increased sodium, then you have increased water, increased ECF, therefore increased blood volume, and therefore increased blood pressure. So your RAS system is really trying to increase your blood pressure, which is why when you learn a bit more in renal next year, that the RAS system can be a really bad cause of hypertension. And then our last big thing is the sodium blood pressure set point. So this is a natural set point that's established by the renal system that will return the body to its set point of blood pressure when blood pressure becomes too high or too low. So basically, for example, if blood pressure goes up, then the renal system will work to like excrete sodium and fluid until the blood pressures return back to normal. Cool. So that's it from me. So thank you so much for your time, and feel free to email me if you have any questions, or email Prof. Wright, who's the expert.
And eventually the